to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, ladies and gentlemen, and welcome to our Caribbean African Targeted Health Improvement Program, CATHIP Health Hour. We're really delighted you've taken some time to join us on a lovely sunny, Saturday morning. I hope it's sunny and lovely and bright where you are. So after this, you can have a bit of vitamin D. But it's great to see you all. Our regular Saturday morning sessions are brought to you in part from, led by the Caribbean African Health Network, working closely in partnership with the Rafat International Development Agency, Croydon BME Forum, the Enfield Caribbean Association, Black Health Initiative, and then the RCCG Royal House. It's great to see you all, RCCG based in Sheffield. It's great to see you all. This morning, we have someone who has been incredible over the last 3 years, month after month or week after week, given to community, who will be taking us through COPD. So anything you want to know, Dr. Kamara is the man, or Mr. Kamara in technical terms, but we like to call him Dr. Kamara. So welcome once again. He's going to present, and after his presentation, there will be a time for taking questions. So feel free, it's not too late to invite someone else to join. We always keep saying knowledge is power, health is wealth, but also it may not be directly applicable to you, but there may be friends, family, loved ones who could benefit from your knowledge. So welcome once again, and I'm going to hand you over to the amazing Dr.
Thank you so much, everyone. Good morning, and thank you for having me. And thank you for that warm welcome, Charles. Now, I don't know what I did, but we talked about asthma a few weeks ago, and then I was told, hang on, you can't just do asthma without COPD, you'd have to do that. So I decided to venture into this big topic. The reason why we're talking about this is because of a few reasons, or a few, nuggets that we need to know about. For one, it is underdiagnosed. For two, it is misdiagnosed, i.e., confused with similar but different respiratory problems, chest problems. And of course, it's the third leading killing disease in the world. In some places, it might be even two. And it just tells you the importance of it. It's such an important topic that the World Health Organization decided to dedicate the 16th of November to COPD. That's just to tell you. Now, as I say, we're talking about empowering, sensitizing, and educating our people. We definitely, in lower and middle income countries, definitely fare a lot worse in comparison to our counterparts who are in the, if you like, developed world. So please note that the 16th of November is World COPD Day. As I would do normally in my talks, I'd always start with an introduction. So what's COPD? Now, you know, looking at it, you can see there, chronic, which actually tells you what is the trajectory of the illness. So it's chronic, and it's obstructive, and it's affecting the lungs, the pulmonary aspect of our bodies. So as it happens, it's not just you know, on its own. It's like a single entity. No, it's like a range of progressive lung diseases. Some can say chronic bronchitis. You may have heard of that. Some would say emphysema. They would have heard of that. You know, and so it's important to know that this is not just one illness. But if you look at it, I thought I would start by showing you the makeup of the respiratory system. As you can see, those who have a very imaginative mind would look at it and would think, well, if you flip this diagram upside down, you see that it's like a tree, and this is the trunk, and these are the branches, and these bits on the right there and on the left there are the leaves. So the respiratory system comprises obviously of the upper airway, which we're not talking about today, but then from the trachea, which is the windpipe, and then it gets to the middle of the chest there by the breastbone, where it divots, you know, and it divides into the right and the left. And the right, as you can see, has got three lobes. So it's got the upper, the middle, and the lower lobe. And then the left, because of the heart here, is divided into two. So you have chronic bronchitis, which affects these bronchs, which are the branches in the tree, if you imagine. And this is what you get. When it's healthy, that's what it looks like. It comprises of rings, and these rings have muscles around it. So when you get inflammation, it swells, and of course it produces mucus, snot, phlegm, and then it causes problems with breathing because it tightens up. As you go further down into the lung, you could see that the end product of that is the leaves we talked about, which are known as the alveoli. So the emphysema affects the alveoli, which is where the gas exchange takes place. So we take in oxygen and we bring out carbon dioxide. So the trees we depend on, it's like a symbiotic relationship. They give us and we give them. So they give us the oxygen and we give them the carbon dioxide. And this is why this happens. This bunch of grapes that you can see down here on the bottom picture, if I can get my, what's it called? But you can see that. So it's nice bunch of grapes. When it's actually diseased, you would see that it's not that like that anymore. You can see that it's definitely lost its congruency, you know. So that's just a preamble. So as I said, it's a leading cause of death. And as I say, it's one of the highest.
Oh, fuck this ass. Oh, suck this ass. Oh, fuck me in the butt. Holy shit.
Oh, dear. Right. Anyway, so 3.2 million deaths in 2019.
Dr. Kamara, you're on mute.
Yeah, please unmute yourself, Doctor. I just muted everyone.
Yeah. Can you hear me now?
Yes, perfect. Thank you.
Yeah, so that's it. So as I say, it's the third leading cause of death. You know, about 3.23 million people died in 2019. Now we know obviously that COVID affected, you know, people all over the world, and I think we lost up to like 7 million, put it that way. And I'd say the vast majority of those would be people that belong to this category of respiratory diseases. Now, as we said already, it's a drain on the economy, worldwide economy, and it affects the elderly more than the younger ones. And in lower and middle income countries, the cause or the risk factors are more to do with pollution rather than smoking, which is mainly the cause here in the developed world as it happens. As I said, it's misdiagnosed, it's underdiagnosed, it can be prevented, and of course, it's sometimes associated with certain professions, the welders, the carpenters, the ones that live in industrialized areas, the miners, the bird fanciers. There's a lot of people. And you can see that in India alone, there's 23 million people that died. And in America, that was 2020. It was like, you could see that the number of people that died were 15 million. That diagnosed with it are 15 million, and yet the ones that were underdiagnosed were 12 million. So it just goes to show you how important this entity we're dealing with is. So the problem is, like when people are told about cancer, everybody just collapses and, you lose every fiber of energy that you have in your body. Same applies to this. So obviously when you're told, because it's a chronic illness, it's a progressive illness, so to speak, a terminal illness. But believe you me, it doesn't mean because you've been diagnosed with COPD, that means that's the end of the world. No, it's not all doom and gloom. There's certain things you can do that would improve your quality of life, your lifespan, and you can live with it. You can live a fulfilled life even with COPD. So the way, obviously, of dealing with that is, obviously, you will be confused, scared, and overwhelmed. The first thing is to take the first step, to get things moving forward. And there is something called a decision-making tool, which is one that assesses your lifestyle. It guides you through giving you some information to consider and choosing a bespoke treatment option. So it's not like one size fits all. It's one that would be bespoke for you. It's specific for your needs, which will be different from the other person's, and that could be done by your healthcare team, as well as your doctor, led by the respiratory team. Once you've got all of that, you then have something to play with. So, let's go into what chronic bronchitis is. It is obviously a chronic, as it said, when it flares or if it irritates the bronchs, that's the branches we talked about, these tubes. And these tubes break down into smaller ones called bronchioles, and they further break down until they get to the end where you have these alveoli. And so as things happen, when you look at them under the microscope, you can see they got like some hair-like structures inside the bronch called the cilia. Now, they normally work like, if you have, for want of a better expression or, analogy, like the wipers on the car, on the windscreen. So they sort of mop up. Anything that is there that is heavier than air, like secretion, snot, phlegm, and all that, is mopped up and is actually sort of pushed upwards so that it can be coughed up and could be removed. When you have chronic bronchitis, this is the process, or this is the mechanism that is disturbed and is destroyed, and so it doesn't help to do that. And as a result, you definitely are exposed to more infection. And when that happens, you get tightening of the chest, and of course, subsequently, you get the wheezing. So we'll talk about that anyway. But there you go. Yeah, with emphysema or emphysema, obviously, it's the breakdown of the walls of those sacs, those grapes. We're talking about the bunch of grapes that we talked about. So the breakdown, and evidently, that transfer of oxygen to the lungs and to the blood is obviously impaired, and as a result, you find out you get a problem with breathing. So you can see here, as I said, nice bunch of grapes when they're healthy, and when they're not healthy or diseased, you can see them. That's been destroyed, and so therefore they're not doing what they normally would do. With here, you can see how it is in the bronchs, the tubes. And of course, when they're diseased or when they're actually inflamed, you can see it's tight, it's swollen, and it's got a lot of phlegm. So that's just showing you, as I said, if you turn this diagram upside down, that you can see that, the trunk is the windpipe, as I said already, the branches are the bronchs, and of course the leaves are the sacs that we talked about earlier on. So having said that, it's important to remember that there are risk factors and causes. Now, of course, this is not exhaustive by any means. However, in the developed world, I keep repeating, 90% of the time, COPD is associated with smoking. But the trouble is, not all smokers develop the disease, and I want you to know that they are at higher risk, but that does not mean because you smoke, that means you would actually definitely get it. Completely not the correct mechanism and not the concept or the context that you actually would think it actually formats itself. So if you're age 65 and above, you're definitely more at risk. If you live in a very polluted, industrialized area, region, definitely you're more at risk, as is the case with our people. You work with chemicals, fumes, or dust, as I've said already. And of course, this one that is actually underdiagnosed because some people don't know they have it. And that is why if you were faced with making the decision, the first thing a doctor would do before diagnosing you with COPD is not only taking the history and examining you, but also when they come to assessment, they would want to do a blood test to see whether there's this alpha-1 antitrypsin deficiency, AAT, as it's known. So this is where sometimes people say COPD can run in families. So this is why, because of this, people who lack alpha-1 antitrypsin would definitely be at a higher risk of developing COPD as opposed to the others, So, and of course, if you have diseases in childhood related to the chest, like asthma and things like that, clearly you're more at risk. But there you go. So the impact of smoking, we know already. It damages that hair-like structure, which helps to do the job to remove the mop-up, And of course, when that doesn't happen, you are prone to illnesses. It causes atrophy. So the lungs are very elasticated in their natural domain or format. When the nicotine actually affects them, they become rubbery. And with the rubber, as you know, they can't, discharge their duties. They can't extend and, expand and contract as they would. And therefore, that residual aspect of it is what makes people more prone to infections, Now, I like this slide, and I hope you will do, because, as I said, COPD is underdiagnosed. It's very similar to asthma, to other illnesses that affect the chest and the respiratory system. So because they all present with shortness of breath, difficulties breathing, wheeze and all that. But COPD is a chronic illness and it's progressive. So it's got stage 1, stage 2, stage 3, and stage 4, which is the end stage, mild, moderate, and severe, if you like, end stage. With asthma, it's often offset, it's like set off by allergens when it's an allergic aspect of it. But of course, sometimes it could be an inflammation. And to top that, you could have both. That's the interesting thing about it, So you can have both. And if you have both, then sometimes you may need to treat both of them, And of course, COPD is mainly associated with smoking in the developed world. The asthmatics don't automatically develop COPD. And likewise, the COPD patients do not always have asthma. But as I said, they can coexist and you can have both of them, It just is just a dramatization of what it looks like. The normal airway looks like this. And then you could see what the asthmatic airway looks like. And during the attack, this is what it looks like. The swelling and causing secretion and inflammation and tightening. And as a result of that, you get the wheezing. So the symptoms and signs. Now, obviously, we know that people can cough. If you drink water or any juice and it goes through the wrong way into the windpipe, you will cough, cough, cough. But if you have a cough with mucus that persists for a long time, long periods of time, and with that you have difficulties taking a deep breath, and of course you get shortness of breath when you exercise, just mild walking or maybe going up the stairs, and you have to be, you're wheezing, tight-chested and all that, then obviously you need to be checked out, if it's a cough that actually gets worse, say in the early hours of the morning, you know, you need to be thinking about getting checked out. You may well have it, but maybe you don't know. And of course, you get mucus with it. And if the mucus is yellow, green, or brown, sometimes it may well be because of an infection. Maybe you're asthmatic and not know it. You might be mildly asthmatic, but it may be early stages of COPD that you're not aware of. So, and of course, because it wakes you up in the mornings, early hours in the morning, the coughing doesn't make you sleep. You then fatigued, you're tired during the day, you know. And because the mopping up action is not taking place, you're more prone to frequent chest infections. That is something to look out for as well. If they keep recurring more frequently, then you need to be checked for that, you know. And when it's in full flow, you definitely, people will observe that your fingernail beds are sort of pale and maybe you'll be blue around the lips. That's another thing to look for. So if you have any of the signs, please do not wait to get help because it is important to remember that airway problems can kill you, and are the first ones to kill you. So therefore, you need to take prompt action. Don't wait for the symptoms to become severe before you start taking action. By then, it might be a bit too late. So therefore, it's important to act in time. And literally, a stitch in time saves 9. And it's definitely operational in this particular context. But one thing I want to advise is for people to never change. I repeat, never change or stop taking their medications which have been prescribed, having gone through, you know, the decision-making tool and all that, without first talking to your healthcare provider or your doctor. It is important because you might be harming yourself in so doing, you know. So remember, the signs of a flare-up, because it's a chronic illness, definitely does not in any way mean that the next flare-up or the next attempt would actually, the next issue or the next, time that's an infection, it will be the same. They may differ, but you get the same symptoms, and so therefore you need to be mindful. So you can care for them at home. There's no questions about that. You can care for them and you can care for yourself. If the symptoms are noticed and lasting for more than 24 hours, then you need to be making strides towards, getting the doctors to see you, or even the GPs to see you. If you're getting more tired because you're working harder to breathe because the muscles tighten in the bronchs, then definitely you need to be looking at that in terms of going. If you're using your inhalers, the salbutamol, the bumetanide, and Pulmicort and Seretide and all the other fancy ones they have now, if you're using them more than you would normally require to, that's a sign to say you're dipping. And something we call peak flow meter, which helps as well, but that's more in the case of asthma. And as I say, if you have to wake up at night to try and get yourself, better breathing, then definitely if you have to use the pillow and all of that, clearly it's a sign to say you need to be making strides towards going to the hospital. So if you produce sputum, you're coughing up phlegm, then you need to look at the context of it, the consistency. Is it thin, is it thick, has it changed? And if it's changed, does it smell pleasant or not, or whatever, all of that. If it smells putrid, unpleasant, it looks a bit, pussy and all that, it is tainted with blood and it's thicker than it is normally, then clearly you need to be making signs to making strides towards going to the hospital and getting yourself checked out. Now, the unfortunate thing here is sometimes you may have other organs in the body, other systems in the body that would actually overlap into the chest, i.e. the ankles could be swollen, the feet could be swollen, the legs could be swollen, and normally that does happen. Sometimes if you take tablets for blood pressure, they can actually have a side effect of having the legs swollen, what we call fluid retention, like edema. But when you lie down, you put your feet up, up puffy and things, they will go away. But if they don't go down, the swelling doesn't go down, then obviously that's something to worry about, because it could be a sign of the kidneys not working properly. It could be a sign of the heart. It could be a sign of the liver. So therefore, it is important to get checked out when these things persist. If you're losing weight, and you don't know the reason why, inexplicably you're losing weight, you need to obviously, get that checked out. Headaches and dizziness, being tired, fatigued, flu-like symptoms, all of that, and of course, increased confusion. And some people increased forgetfulness, slurring of the speech. These are all telltale signs, that you need to be checked out. And of course, people get easily irritable and all that. So all of these are telltale signs to help you, to guide you towards, getting checked out. And that brings us nicely to how do we diagnose COPD? Evidently, we always, as doctors, start with the medical history. We would ask you, do you smoke? And if you do smoke, how long have you smoked? And how much do you smoke? Some people might smoke from 1, and now they end up smoking 40. Some people might smoke the pipe. Some people might smoke the shisha, which they think is recreational and all that. Some people might vape. It's now becoming the in thing. So all of these are important to take into consideration when making a diagnosis. And of course, it's important to consider exposure to dust and to pollution, air pollutants, definitely. And the one big question that we always forget to ask is whether it runs in families. Because if you have this alpha-1 antitrypsin deficiency, then clearly you would have to be screened, and maybe your immediate family members, your first-degree relatives, would have to be screened in order to prevent that happening. Of course, how do you tolerate short exercises or small exercises? Do you have to be resting and things like that? Do you get out of breath at rest or at, when you exercise? Do you have a cough or a wheeze, and has it been for a long time or not? Are you coughing up any phlegm? And if it is, what's the amount you're coughing? What's the color? And what's the consistency? Then of course that would be followed on by a physical exam, which includes listening to your heart, your lungs, checking your blood pressure, your pulse, your temperature, the number of times you're breathing, and of course they would sometimes look in your nose and throat, because sometimes you may well have a polyp there. So people who have polyps sometimes would have that kind of problem. And of course, as I said already, they'll check your ankles and feet to check for swelling, and with that they will continue to the diagnosis. Now obviously you have tests you can do, but I thought I'd pay attention, or maybe draw your attention to what we do in terms of investigating for COPD. Now on the right you could see that this is a chest x-ray. For those that don't know, this is what the x-ray looks like, showing your ribs, which are the strip. This is the strips. You can see that the ribs, and of course this white bit here, this organ sitting like a duck, is your heart, and this black bit here is your windpipe. So it then gets to this point, and then it divides to the right there and divides to the left there. In the right, this bit is your lung, which, as I said already, consists of three lobes. So 1, 2, 3, the upper, the middle, and the lower. And on the left, because of the heart, it's divided to just 2. So that's big one and the bottom one there. And you can see nice, beautiful cupole of the diaphragm, really nice, lovely here. Same here on the left. Now that diaphragm is what divides the chest. So the contents of the chest are up there, and anything below this diaphragm is in the belly. And so you can see our good friend here, the abdomen, which is illustrated here. So that's what it looks like. But without the markings, there's a lot more in this picture, but I don't want to dwell into that because we're looking at the chest and that's that. And here you can see what it looks like, fine, nice. But then compare that to these, and you can see for yourself that definitely these pictures are very different, and that's what COPD does to your chest. So over the years, because you're developing this, it actually causes the problems with the ribs, the muscles, and so it becomes what we call a barrel chest. And because it's now the lungs are, sort of rubbery, they're all hyperinflated. That's the term we use. And you can see that nice cupole that we had in the other diagram is now completely effaced. It's now almost flat. It's not there anymore. You can see a small collection of fluid there, and the same applies to this one. This is the heart, Again, look at this. It's so atrophied. You can see that. Normally, you can't count this number of ribs on an X-ray, but here you can count up to 10, which is really, really, a sign to say that these lungs are definitely atrophied, and there's no chance of getting them better again, back to how they were before the smoking or the exposure to the pollutants. This diagram just illustrates what we've been talking about already. How you diagnose and how you treat and the rest of it. So the tests we mentioned, are that you would get something we call a pulse oximeter. I think you all know about that because people have been using that when the COVID pandemic was on, putting it on the finger and it measures your oxygen in the blood. And then, of course, when you come to the hospital, we get this blood test. It's very painful, but we try and make it as less painful as possible. This is the arterial blood gas, which checks your oxygen and the carbon dioxide levels, because the carbon dioxide could be poisonous to you and obviously cause you problems. So therefore, it is important to check that. And of course, because the legs and the ankles swell, you want to rule out the involvement of the heart. So therefore, you'd have to do what we call an ECG, otherwise known as a heart tracing. The Americans call it the EKG. And with chest X-ray, we talked about already. Sometimes we need to proceed on to a CT scan, computer tomograph of the chest, to aid the diagnosis and look for changes that may well indicate that there is some, sinister problem going on. I must not forget that spirometry is a good test to have. When you get to be diagnosed or maybe tested for COPD, you would have to look at the lung capacity, how it performs, what's the volume remaining, and how we can actually help you tolerate the exercises that would help build up, Then, of course, we then need to look at the stages. As I said already earlier on, there's a mild stage, there's the moderate stage, and there's the very severe stage. So first sign of COPD sometimes, we feel we're out of shape, going up the stairs and things, we blame that on, just getting older and, thinking, well, nothing is wrong. But if that is supported with a phlegmy cough and most often in the mornings, then maybe you need to be checked out with the possibility of having early stage COPD. And the earlier you get it diagnosed and treated and planned for, the better you will fare. The better you get to cope with it and the better you could, feel in terms of going forward. And then, of course, that progresses to the moderate to severe stage, which then is illustrated by the shortness of breath, which is more evident. And by the time you progressed onto the severe stage, then it's almost everything you do causes you shortness of breath, and that impacts on your mobility. So you're more static, really. You may need supplemental oxygen, which you see on people. Now, I've got videos that will show you that. On the right, you see, the strategies of helping to combat this killer disease, this illness. There's stage 1, stage 2, stage 3, and stage 4. So those who are interested, I can share those with you, and you would actually be able to learn from that, and maybe it'll be beneficial to you. Then, of course, we can't finish without talking about treatment. Now, treatment is mainly symptomatic, which means you're relieving the symptoms. And we know the symptoms are obviously chest infections, shortness of breath, difficulties breathing, And so what you do is if someone comes in coughing and having breathing problems with a temperature and maybe, being unwell, then, of course, you have to, first of all, open the airway. And the way you can do that is by giving these bronchodilators, which relax the airways and they help you breathe better. And then, of course, you give anti-inflammatories. Some people think it's anti-inflammatories. There are two types. There's the steroidal and non-steroidal. Now, this non-steroidal we know already, like ibuprofen, diclofenac, naproxen, and all that. Those help for things like pain and inflammation and all that. But these are steroidal, so you give the steroids in the form of inhalers or in the form of tablets, and in some cases, the form of medicine liquid, which would help to dampen the inflammation in the lungs. As I said, if you need oxygen, it could be given to you in phases. Maybe at an acute exacerbation, you get that. But when it gets to the latter stages where it's definitely getting to the severe stages or end stage, then you might need it at home, And of course, if you have an infection, which we know is possible and it's always there lurking because of the fact that the mechanism to mop up is not as effective as it was, you probably might need some antibiotics to help you along the way. Sometimes you might need 2, because we need to think about the atypical bugs that would cause that. So sometimes you need 2. And as I say, it progresses. There are pathways to follow and they will help. Then, of course, we mustn't forget that because of that, we have problems with the immune system. And so therefore, we need to top up on our vaccinations on a regular basis. So there are pneumonia vaccines, and of course they have the flu vaccine. And to top that now, we have the COVID vaccine, which obviously we recommend once a year to people who are at higher risk, especially the asthmatics, the COPD, the tuberculosis, and all the other upper respiratory or lower respiratory tract patients, And then, of course, the rehab is a good thing to have, because that does help to sort of increase your tolerance, and of course the breathing and the fitness. It does help in the trajectory of the illness, as it were. So these are all, other forms of treatment. Now, one thing you might not have heard of is the clinical trials. So the respiratory clinicians or the GPs might talk to you about being considered for clinical trials, which are just a way of advancing, treatment of certain illnesses. And of course, sometimes long surgery is also recommended, but it has to be on an individual basis, i.e., it's something bespoke. So they will have to assess you, eligibility, and of course, whether it would be helpful to you or not, really. They give the antihistamines. If there's an element or you have a hint of an allergy component or allergic component to it, then clearly, antihistamines do have their own roles. Of course, if you have the flu and you have underlying viral illnesses, then obviously the antivirals might help. The anticholinergics are all helpful, but that's more to do with the medical technical stuff. Something to help you cough up the phlegm is what we call expectorants. It's also the carbocysteine, some people might know, that helps as well. So obviously, we always talk about, diagnosis, treatment, but then importantly, we need to delve into prevention of infections. So once you have been diagnosed with COPD, and by the way, the respiratory clinicians do not like diagnosing COPD to the under 50s for obvious reasons, because once you label someone, it's a tumultuous task. It's a Herculean task to be able to unlabel that person. So it's important to remember that. And so what would help you with prevention of the infections is obviously washing your hands with soap and warm water before. This is preparing the food, and of course before eating, taking medications, and of course it's important to remember that it's not only before, but then after. It's also good to wash your hands, with warm water and soap, because you might cough, you might sneeze into your hands. During the COVID, you sneeze into the elbow that might be covered by clothing and things, you might not see it. As long as it's your hands, using the bathroom, touching soiled clothes and all that, you definitely need to wash your hands, because the bugs might stay on your hands, and so therefore are transferable and even make yourself more vulnerable. So you're like auto-infecting yourself, social gatherings, when you've been or when you go out, you come back in, always try and wash your hands. It helps you, It doesn't go amiss to have a hand sanitizer in the bag or somewhere where you can easily reach it, and help, to prevent an infection. If you've had visitors and you've had people who are unwell, well, try and stay further away from them, because when they cough and sneeze or anything like that, you probably will catch it. And because you're vulnerable, you're not able to cope with the bugs as best you could. And so therefore, you need to protect yourself. So you need to keep your house clean if you want to prevent that, free of all excess dust, because the mites, the pets, the carpets and things like that, keep the bathroom, free of mold and mildew. It's important, avoid working or visiting construction sites. This is more to do with the pollution, the areas where there's high pollution, if you must, then remember to wear a mask. It's important. I know we know that now it's not mandatory, but you need to protect yourself. So therefore, think, you are sort of tipping over the edge, then there's no harm in wearing a mask. It would help you definitely. Avoid tobacco, and of course wood and oil smoke. And the big thing here is the exhaust fumes. I know, in fact, there's a little girl that died in London for the first time in England, whose death was attributed to that. The area where she lived in, the pollution was just too high. and she sadly died, as it were, because of the complications of that. So industrialized areas, obviously, we need to be mindful that we need to avoid them as best we can. Little things like the cooking vents, making sure they're working properly, they would help as well, and stay away from large crowds, in the winter, because this, as you know, is a seasonal flare-up, taking care of your equipment, drinking plenty of fluids. Remember to look at your diet, maintaining a weight that is, in keeping with your BMIs and things. Not that I approve wholly of the BMI way they calculate it, but it helps to have, at least a decent weight that would help you to prepare yourself to get yourself better. Remember, stress is not a good thing, in the sense that if it's negative stress, then it's not going to do anything good for your immune system. So therefore, the positive stress, which is stress to help you like meet deadlines, get to places on time and things and that, is required. It's what we survive with. The flight and fight hormone, the adrenaline, is what we thrive on. There's no questions about that. However, the negative stress will wear you down. It will exhaust you, keep you awake at night. And if you're not getting enough sleep and rest, then obviously the immune system gets run down and you're more prone to getting infections. Remember your flu jab, remember your pneumonia jab, avoid infection when traveling. And if you're going to somewhere where the water is unsafe, then drink bottled water, and beverages. If you're taking them at all, try and avoid taking them with ice, because that's all going to be, making you more prone to catching infections. Follow your doctor's advice, stick to your medications religiously. I urge you, and of course, quitting smoking and embarking on the plan to help you improve is good. Remember, it's not all doom and gloom. Yeah, people have lived fulfilled lives, there's no questions about that. And if, it's their life expectancy can be really good. And it sort of, from one person to another, it changes. There's no questions about that. But it all depends on how that person is. There are more people with more comorbidities, and so therefore they fare less well than those without. But it doesn't mean because you've been diagnosed with that, that means you are, you've been passed a sentence to death. No, people have, as I said, lived up to their ripe age of 80s and 90s, and they died of something completely different, So remember, again, taking several steps, making breathing easier is good for you. Maintain, as I said, a healthy weight is good for you. The rehab program will help you, and take the medications religiously, as I say, and don't forget your. So now I'll play these videos. Hopefully you would benefit from them. There's 2 of them. They're very short, but you would benefit from them.
I had some form of COPD 15 years before the diagnosis. Back then, I was a heavy smoker, very active with family and scouts. Our son is an Eagle Scout. Say, let's keep on going, and you don't have COPD. Keep going. Well, it slowed me down definitely now that I'm 81. Not much has gone wrong with me up until the point where I got this COPD diagnosis. I was kind of taken aback by it and said, well, what's this going to mean? And I found out that it affects your breathing. I did notice it when I was on a business trip in Albuquerque with some friends, and walking down the street, and they're way ahead of me, and it's just, wait, slow down, I got to take a picture. Actually, I wasn't going to take a picture, I was trying to breathe. One thing I would advise people to do, and it happened to me twice, is go to pulmonary rehab. Continue the exercise, get up and move. Exercise, and get some more exercise. The other thing is, if you're not honest with your doctor, you're kidding yourself. He's there to help you. And you better listen to him, because he's got the expertise and the training and the skills to probably improve your life or prolong it. And if you want to prolong your life, you can do that. The mental aspects of COPD are something that really don't faze me or bother me too much. I've never been depressed or gotten down with the fact that I've got COPD. Life is too short for that. I had some.
This is the next one.
Diagnosed with COPD has to be one of the most horrific events in anyone's life. And when I was diagnosed, it was something that really was not talked about and nobody knew anything about it. When I feel that I was short of breath and didn't know why, the first thing I decided to do was to see a pulmonologist. He gave me what they call a pulmonary function test. And then he said that you have 10 years to live. There was no other conversation. There was nothing about rehab. There was nothing about we have classes to help you stop smoking. Nothing at all. 10 years to live. In 2000, when I was diagnosed, I don't know how much is known about COPD, but from then until now, and you walk into a pulmonologist's office and they tell you you have COPD, there's a lot of talking they're going to do. They're going to talk to you about quitting smoking. You have to eat properly. You have to keep the stress levels down. You gotta keep moving. Some type of rehabilitation. You need a support group. You need your family. You need somebody that you can talk to, and somebody to put an eye on you. Open and honesty is the only way that I know to be with my doctor. I'm going to ask the hard questions that he is going to be ready to give me the answers because he knows that I'm serious about managing my disease. Having a caregiver is a plus for me. They're here to help me, but there are things that I just can't do for myself. I don't want my caregiver to just wait on me hand and foot, and it's not necessary. For any COPDer that's listening, just know not to give up. Never give up, never give up. Keep that spirit, have that conversation with your doctor. Let him know what's going on with you and just keep digging for knowledge. I want to know more because the more knowledge you have, knowledge is power.
So I hope you enjoyed that, but you can see you are not alone. This is a family thing. You need every support you need to carry forward and get yourselves to your fulfilled, lifespan. So I thought I'd end by, trying to bust some myths. I mean, you can hear all sorts of things to, put you off, distractors, I call them. But remember, the way to get started is to quit talking and begin doing. So people think that if you smoke and have no symptoms, you probably don't have COPD. Well, we found out it's not necessarily so, because clearly in the early stages, you might not even know that you have it. You might just attribute that to, being out of shape, getting older and things like that. But it may well be that really. So therefore, it's important to remember that. It said only smokers do get COPD. Well, we found out it's not the case. That it could run in families, and you may well be the unfortunate person to have inherited the genes of the alpha-1 antitrypsin deficiency, and which wasn't diagnosed where you are in your part of the world, and so you've come to the Western world, and obviously there are maybe better facilities to actually investigate and get that found out and treated appropriately. Now, there's the myth that once you are diagnosed with COPD, if you stop smoking, things would not improve. We found out that's not the case. As you can see from the videos, definitely you can live a fulfilled life even with the COPD. There's no questions about that. It's deemed to be untreatable. Now, that's not true. It's a chronic illness, but that does not mean it's untreatable. We've seen people survive and outlive the ones who didn't have that diagnosis. So, and it's not necessarily ascribed to the elderly. The elderly are more at risk, but that does not mean they're the only group that would actually be the ones that contract it. Absolutely not. We know younger ones have contracted it. They say once you diagnose with COPD, there is nothing you can do to manage symptoms and live better. Well, we know that's not true, is it? There are many things people can do, to manage the disease. You stop smoking, get exercise done, pulmonary rehab, as we saw from the videos. In fact, I meant to say the pulmonologist is just a term used in America for a respiratory physician in England, so just so you understand that. And patients on oxygen can become addicted to it. Well, that's not very true, is it? Because oxygen, when you come to us in the hospital, we give it as and when you need it. The only time you would actually have oxygen on a more regular basis or maybe a permanent basis is when you get to the terminal stages, i.e. the last stages, that's when that would happen. Other than that, we know that's not true. So I've said that, I've talked a lot, and I'm so pleased, and thank you so much for listening to me. And now I'll stop sharing, and maybe we can get some questions and answers sorted. Thank you so much for having me.
Great, massive thanks, Dr. Kamara, as always. And we have quite a number of questions for you.
Oh boy.
So I'm just going to crack on. The first one is, I have asthma, which is so much worse in the summer, finding it difficult to manage, and the inhalers help a bit with breathing, but my chest still feels heavy. What can I do?
Well, if you say you've got asthma, then obviously you would have a healthcare worker. You'd have what we call asthma nurses who are consultants. You have a GP. You have a respiratory consultant who would definitely be your port of call, if you like. So if you are doing all you have to do, and you're doing it religiously, then obviously if you're not feeling the way you should, then I'd advise you get checked out. In fact, they should be seeing you 6 monthly, if not maybe at least annually. The longest you get seen is 6 monthly or 12 monthly, but definitely. And the other thing you must remember is it's a seasonal illness. And so therefore it flares up in those times when the pollen count is high, and when it's definitely cold. So that's the kind of thing you have to remember. But it's important to know that if you're feeling that you're not responding as you should, then get in touch with your healthcare provider. They would support you to the hilt.
Brilliant. Thanks for that. I'm going to go to one in the chat box. Someone is saying, I'm really interested in vapors and COPD. Is there any information about vaping that causes respiratory problems? Because there are so many of them that vape and they don't smoke cigarettes. So
I say it's a topic for another day, but suffice to say that it's causing a lot of problems. Vaping is now becoming the in thing. It used to be glue sniffing and things like that. Nowadays it's vaping. Even the youngsters, they're taking to that. They're thinking it's fashionable, and so therefore they're using it. Now, obviously, if you look at the component parts of the vaping, you would see that they're not without risks, So before you put that thing into your mouth and start inhaling it, you better think about what you're putting in there and see what it does to you. It's important to remember that. There are other ways of actually tackling this illness. If you want to stop or give up smoking, there are ways. You have, gums, you have patches, you have even hypnotherapy, you have support groups, you have literature and all that. These are things that are there to help you rather than sticking to just vape. Vape obviously hasn't got the nicotine, which is what we're all talking about. But I'll be honest with you, the component parts of that vape, we're still to find out, and the effect or the long-term effect, we're still to find out. But people are misusing it, and it's not helpful. I can, tell you that.
Right, thanks, Dr. Kamara. And for the person that asked the question, I've just posted a link because I think it was this week, the chief medical officer, did put out something, out there about the dangers of youth vaping. So, the link is in the chat box, and I will encourage you to spend some time and, read that. That will be helpful. Yes. So the other question, I noticed during COVID that my hay fever symptoms improved and now it's worse again. What could be the cause? Is it because I was wearing mask?
I'll be honest with you, that may well be just an isolated observation, and you can never say never in medicine. But you'd have other people tell you that when they put the mask on, it irritated them and they were actually short of breath. And remember that there's the component parts of the fiber that is used, or the material that is used in making that. It's got fibers, microfibers, you might just have them and they can irritate you. But if you found out that the masks were helpful, that may well be because you want probably taking in the bugs, if you like, that were responsible for the flare-ups. So that does help. This is why I mentioned in my talk that if you know that where you're going to, you're not sure about the safety of the audience, and you're prone to getting these infections, then obviously protect yourself. Put a mask on. No questions about that. I don't think anyone will look down on you or look at you in a funny way because you've got a mask on. It's something we've had for 3 years. We've only just about managed to get rid of them. But there's always the option that you would definitely have one, if you need one. So I don't think there's anything that is related to any medical science to say that if you wear the mask and if you don't wear the mask, the asthma will get better or the COPD will get better or not. Obviously, flare-ups, the infections, if you're close to someone who's got an infection, he sneezes or coughs, and you catch that, you might not be able to get rid of that or shift it. So therefore, look after yourself by wearing the mask.
Thanks for that, Doc. During your presentation, you mentioned having COPD is not, a death sentence. So just want to check with you whether, people's lungs could actually recover.
Well, I need to clarify. When I say death sentence, people think, well, that's it. You've got COPD, that's it. You're just going to die. That's why I said it's not all doom and gloom. It could be the mild stage, the initial stages. And if you take the necessary steps to help with that, clearly there's no reason why you can't live for another 20 years or 30 years if you're doing what you have to do. It's as simple as that. So the fact that they say death sentence, well, because it's a chronic illness, it's got ups and downs. It's got flare-ups, relapse and remission. There's no questions about that. You will expect that in any chronic illness. But the fact of the matter is, it doesn't mean because you've been diagnosed with COPD, that means you are sentenced to death. No. The lungs, obviously, imagine you are smoking for 40 years. You don't expect that to be turned around in one day. Definitely not. And as you grow older, the immune system becomes weaker, as it were. So you got all the odds stacked up against you, and of course, the lungs, which were made to, help you with your breathing and your ventilation and all that, are now not as elasticated as they were. They're now rubbery. So therefore, it wouldn't be the same. Even if you prevented the infections happening, you wouldn't get back to how it was because they're all hardened by the nicotine and, of course, the other pollutants. So it's a question of making you pardon the expression, making the best of a bad situation. I don't know if that answers the question.
Okay, thanks. I'm sure the listener, will come back if, they want further clarification. Also, Doc, whilst we're talking about this, obviously it's related to chest and just wondering, are there any NHS immunization programs available for those over 65 that can help with reduction in chest infections?
Well, I mean, the flu jabs are there for everyone. And in fact, the GPs are very good at sending you the reminders, the notifications, we get them all the time, all the likes of us who are in the front line. Of course, people who are in that category of high risk, they obviously offer them the pneumonia vaccine as well. So they're there. And they're done, religiously every year. There's no questions about that. And now we've got COVID, which is there as well. So the top up, the boosters and things, they're there, available for everybody who fits that category. I mean, I am really proud to say that this is a robust system that works. but it's just for us to actually increase the awareness and educate our people as to the relevance, the importance, the significance of protecting yourselves. So when you are offered the opportunity of taking the shot, don't look a gift horse in the mouth. Go for it. You'll probably be pleased that you did. Because as we know, influenza kills. Pneumonia, we know, definitely is a killer. There's no questions about that. So if you offered that, go for it.
Yeah, thanks, Doc. I think back in your presentation, you did refer to, the young child that died due to air pollution, and we know the impact of poverty or living in, deprived areas and the risk from pollution. So, what would your top tips be for people to look after themselves if, unfortunately, the housing they have is not in a greener environment?
I mean, this is probably more of a political issue, but obviously tethering on health. And I know for sure that health is wealth. In fact, the program that the health talk show program that I founded is, health is better than wealth. And we know that if you have a healthy population, your economy will definitely boom. There's no questions about that. So we need to look after our people, and we need to sensitize them. We need to educate them. We need to get them to attend talks like this so they know what to do. If they're renting, then obviously there should be legislations. There should be a legislature. There should be statutes which would hold the landlords and the landladies, or whatever you call them, responsible to actually provide safe housing. It's important that now, whether be it the government, whether be it the buy to rent or let to rent or whatever you call it, scheme, it's important to remember that there are people whose lives are at risk, and so therefore they need to be living in certain conditions that would definitely be commensurate to a good life. You know what I'm trying to say? So when you get mold and mildew and all that, and you don't have fit for purpose, fit for life buildings, then clearly they need to be scrutinized. They need to be brought down. They need to be brought to the book. And so people themselves have to be able to highlight this and take it through the right channels. But obviously, the governmental aspect of it has to be looked into. The legislature that needs to be looked into has to be improved as required. So it's not a unifaceted, it's a multifaceted problem, and we all have to be involved in it. We all have to dig deep and make sure we are all, so to speak, singing from the same hymn sheet, if you like. So, but we need to do our bit, and as I say, and leave the legislation aspect to the government to see what can be done to improve the life standards and the health status of the country as a whole. But because we are more at risk, it's probably important for us to highlight it, and how we do that is probably what we need to be looking into, really.
Thanks for that, Doc. Going back to the chat box, there's a question about flu jab and whether you're going to advise children take it whenever they offer it.
Well, I mean, the pediatricians do have the vaccine schedule, they would definitely advise you best as to what needs doing. But there are children, as you know, who are vulnerable, who are more at risk, childhood asthmatics, premature babies, children who are born to families where there's, chest problems and things like that. They need to be assessed, as I said, a bespoke management plan is what is required, So if you don't need it, that's one thing. But if you do need it, then make sure you get it when it's offered. It's as simple as that. But of course, the pediatricians would have advised you better as to whether the flu jab is for every child or whether it's specific children. I know with the adults, clearly, it's important for us to all have it because you never know when the immune system dips. And if you are vulnerable or you're prone to infections and you've got chronic illnesses, then clearly you should be at the top of the queue. There's no questions about that.
Great. Thanks for that, Doc. So, great audience Just to remind you, this is being live streamed. It's available on YouTube, but also for the next 10 minutes or so, we do have opportunities for you to put your questions to Dr. Kamara in relation to the topic or any other questions you might want to ask him. He's an emergency consultant. Also, we want to get some feedback from you, so you would have seen a survey pop up on your screen. Try and answer that. So, Doc, continuing with that, you've touched a bit on prevention, and it will be good to sort of recap how people can look after themselves to prevent that. And then we will move on to some of the practical things people will do, because someone is asking about singing and whether now that they've been diagnosed, what are some of the practical things they can do, to support their lungs?
Well, I mean, as I say, singing as a profession is reliant mainly or chiefly on the voice box and the windpipe and things, and the lungs, of course. Now, sadly, in the event you have COPD diagnosed, you're hoping that it's in the early stages where you can manage things. But as I say, age, doesn't help. And as you grow older, obviously, the voice box would not be the same. And if that is topped with nicotine that is bashing it on a daily basis, clearly it would age faster. And of course, you're straining it, because professionally, that's what you do. You're straining it all the time. In itself, it's got its own side effect, the singing, I mean. So if you are diagnosed with COPD and you're a singer, well, of course, you have, as I said, a bespoke plan. And I can't tell you what the plan is now until I would have gone through certain, if you like, a certain chat with you, looking at what it is that you could do prior to now, and how you functioned and what you did and all of that. All of that needs to be taken into consideration. And I think the best person to do that is either the respiratory physician who's looking after you, or the healthcare provider in support or with your GP, because they know you better and they know exactly what you used to be and what you are now, and they can compare and come up with a bespoke plan that actually fulfills all the requirements. But definitely, it's a health hazard to the voice box when you are a singer, and of course, COP doesn't help matters. That's what I can say on that.
Okay, thanks, Doc. Another question for you: what causes scarring of the lungs, and why is it that you may have it, even though you've never smoked before?
Well, I think the answer is there in the slides in the talk itself. As I say, in the lower middle income countries, it's more like 30-40%, is smoking related, but the vast majority is obviously related to pollutants. People use firewood to cook, people use coal to cook, people use, they're more into carpentry and all that. Without the mask, without the preventatives, they live in the urban areas where there's a lot of pollution, as it were, the fumes from exhausts, all of that would definitely impact the health of the nations, that we're talking about. There's no questions about that. In the Western world, it's the opposite. COPD is mainly related. 70% of that is mainly associated with smoking. But of course, we have what we call passive smokers, as it were, those that live in pubs, the publicans raise their children in pubs and things like that. They're all passive smokers, those that live in industrialized estates or industrialized areas. All of that, are definitely, factors that, influence the rise of COPD, as it were. So, this is something that we all need to rise up and, as I say, pay attention to and see what we can do to actually prevent that from happening. It is preventable, but as I say, we need to be collective in our thoughts, in our actions, to help to move this process forward, really.
Great, thanks, Doc. Talking about pollution and various jobs, and I'm wondering, are there any comparative studies between COPD in the developed and developing countries?
Well, I mean, it's difficult to come by the statistics, as it were, There are a couple of papers that I've seen, but they themselves, as I say, are more to do with, if you like, the way of life, as it were, poverty, and of course, if you like, exposure, education, and availability of the necessary services, facilities that are required in order to improve, the state of health. These are all factors, so you get availability, affordability, accessibility, and of course, the big, if you like, problem there with poverty, which obviously subjects you to certain things that you wouldn't necessarily readily want to do. But of course, you are in a situation where you've got to strive and stay alive and do things that you have to do. So unfortunately, it's not a problem that you can just look on and say, well, okay, this is what solves it. It's a multifactorial problem. It's a multifaceted problem. It's a multi-layered problem. And so therefore, it's not a case of one size fits all. But clearly, in the lower to middle income countries, as I say, this COPD is actually number 2 in some areas. In children, it's also just under something like respiratory problems. But clearly, it tells you the importance of it, to the point where the World Health Organization has decided to dedicate the 16th of November to World COPD Day. So it just tells you how significant it is.
Right. So two more questions and then we shall wrap up. One is, I had pneumonia 3 years ago. My breathing has been fairly shallow since then. I've put on a lot of weight and I am restricted in terms of mobility. The nebulizers are not effective. What do you suggest this person should do?
Yeah, well, as I say, it is interesting. I think the answers are in the talk. It's like you are just saying exactly what I've just said. Maintain a weight that is ideal. So the difficulty here is, how do you lose the weight when you are your mobility is impaired, if you like. It affects your mobility because you start walking and you get short of breath. You have to stop and think. So it's like a vicious circle. You see what I mean? And of course, you've got the COPD things. Now, you've had pneumonia 3 years ago. What I don't know is what has been done about it. Have you been assessed? Have you been checked post-recovery? Has the spirometry been done? And if it has been done, what's that? And have they looked at other issues that may well be causing these problems, like the heart? It could be early onset heart failure. You might just be thinking you've got shortness of breath. It's just related to pneumonia, but in actual fact, you might need a cardiologist. You might need an echocardiogram. So you want a series of things to be done. You need an ECG to see, because these things can overlap. As I said, the heart, the lungs, and the kidneys and the liver, they all can sometimes overlap on certain things. And this being one of them. So if you got ankles that are swelling, legs that are swelling, and that's not in relation to the medication you take, and when you lie in bed at night, you put your feet up with a pillow or two, and in the morning you still have that, then of course you can't lie flat. You need to have 2 pillows or 3 pillows and all that. These are all telltale signs. They're all telling you that, look, this is not just pneumonia. This is not just scarring of the lungs. There's something else going on that needs to be looked at, that needs to be checked out. And once you get it checked out, I guarantee you, you'll get a bespoke plan, which would help you going forward. And of course, you've got dietitians, who would come into the picture. You've got physiotherapists. You've got what we call chest physiotherapists, they would help with that. And so, as I say, it's doable. It's definitely doable, but you need a few specialists coming together. And as I said, if you channel that through your GP, and who can then get you to be seen by a cardiologist as well as a respiratory physician, I'm sure they will format a plan for you with you at the center. That's the key thing. You need to be involved in decision making. And with the willpower, you definitely can sense some improvement if you are compliant with what is prescribed for you.
Brilliant. Thanks a lot, Doc. It's so reassuring to know that it's not a death sentence. So 2 more things and then I shall hand over. And also when you answer that, you can give us your closing remarks. Someone wants you to confirm whether the lungs can cause other organs to fail, such as the heart. And then the second one, when we talk of smoking, I know we refer a lot to cigarettes and then vaping, but obviously in our community, there will be people who like the weed or cannabis. And I'm just wondering whether there's some evidence based out there in relation to that.
Well, I mean, the cannabis thing is a subject or a topic for another day. Obviously, we know, what it causes and things like that. Now, let's say anything that you inhale into the lungs is obviously, dangerous and detrimental. Now, a one-off thing is one thing, but when you're doing it on a daily basis, because remember, it's addictive. So you're going from one cigarette to half a pack, to a whole pack, and sometimes two. And it's not just restricted to the cigarette itself that is, in packets. It's also to tobacco that you put in the pipes. People used to say, well, if you smoke in the pipe, it's less. Well, even so, harm is harm. And that's it. You can try and justify it and quantify it all day long, but it's harmful. And of course, cannabis, we know, has got other ingredients, other constituent parts, which are definitely harmful and very, very negatively impactful to the brain, to the whole body well-being and things like that. So, if you don't, as I say, if you want to protect yourself, it's a God-given right to protect your body. It's given to you to use it as appropriately as you should, and not, misuse it, neither cause it any harm. That is my take on that. Look after it. It's a gift. Not many people have it, because some people look for it, want good health, they don't have it. If you have it, cherish it. Look after yourself and protect it the best way you can, really.
Thanks, Doc. And then the one about the lungs being able to cause the...
Yes. I think I hinted on that. I said there's something which a lot of people don't know about. It's called cardiac asthma. So it's like asthma, but it's related to the heart. The heart failing, I've just answered that probably 2 questions previously. When the heart fails, again, the shortness of breath, difficulties breathing, and of course the treatment differs. But I'll give you, I don't know if I have enough time, but I'll give you a small example of somebody who, I was actually standing outside my department and talking to my secretary, and all of a sudden I saw this ambulance wheel somebody in. And I just took a quick look on, on what was happening, and I saw this man, and I realized, oh my God, I think I'm needed there, because I knew this man will die. And that's not because I'm bigging myself up, but I just saw him. I knew my diagnosis straight on, maybe years of experience, maybe whatever, but I just looked at him and I knew. Because as he was trying to breathe, I saw the scar in the middle of the chest. And I knew then that there's something there, not necessarily 100% related to the lungs, but it's something else to do with the heart. So, and it was compounded in view of the fact that this man has just had surgery about 10 days ago to the lower leg. So they got him in, and of course, the doctor who was seeing him, I knew he was overwhelmed, and he knew he was out of depth. So I stood there supporting him. I was supposed to go to another area, but I went to that, and I knew that had I not been there, it would have been a bit difficult, because probably this man would have, So the treatment that we actually sort of offered him differed from the treatment I would have given to someone who's asthmatic, who's got a flare-up. But you start off with obviously opening the airway, because the airway is what would definitely take you out. There's no question first than anything else. If you get stabbed in the belly, it might take 10 hours, 15 hours, 20 hours. But the airway, if it gets to get closed up on you, then clearly within minutes, you're gone. So this man needed something doing to the airway. We did that. But then lo and behold, I knew then that this man has got a problem with the heart. And of course, it was the heart failing. So he's got acute left ventricular failure, what we call it, heart failure. And so the treatment is trying to offload the heart, because the lungs now cannot cope with what is being thrown at them. So you're flooding the lungs, so to speak, and what we call edema, pulmonary edema. It's like there's nothing for the lungs, and the lungs are supposed to be air. They just have, just filled with air and nothing else. Anything heavier than that would cause them to deteriorate. And in this man, he wasn't able to do that. So we started giving him something to actually decongest, the heart in keeping with the lungs. And in that way, after 40 minutes of trying hard to get him, he actually called for me and said, "Oh, thank you, doctor. Can I have a cup of tea?" I was like, I felt fulfilled that indeed I probably made a difference to this man's life, because he was on his way out. There's no questions about it.
Thanks, Doc. We are just out of time, but before you go, I think this is important. Someone is asking about cleaning products since you talked about inhaling. So if someone is a cleaner and has to use strong detergents on a regular basis, someone is asking whether that's harmful to the lungs and
What I say, risk. This is more to do with the asthma, because I know people. This is a professional hazard as well. I mentioned that. If you're using detergents like in the NHS, the latex gloves and things like that, they're all. If you're allergic to it, then clearly, please look after yourself. You have occupational health who would actually look into that and try and see what best they can do for you. But as someone who uses detergents and cleans, it wouldn't harm you to put a mask on because the fumes would be less via the mask. It's as simple as that. Just simple measures like that. If you know you're allergic to it, then maybe try and protect yourself better as opposed to exposing yourself to it because that is you're trying to get a living or maybe fork out something or put bread on the table. But in so doing, you're exposing yourself to health hazards, and of course you won't be any good to your family who you're trying to provide for if you are unwell. So look after yourself. That's all I can say, and try and take the preventative measures to get yourself better and fit to get the wealth you're looking for.
Great. Massive thanks, Dr. Kamara. I will hand over now. We're grateful to have you, and then probably hoping to bring you back in the next few weeks to look at cannabis and, let's really unpack that and some of the harm that causes. So I'm going to hand over to Ruth, and apologies if we've not answered your questions. We will find ways to, come back to you and give you some response. So over to you, Ruth, for a couple of announcements.
I hope everybody can hear me okay. Okay.
Yeah, we can hear you.
Okay, great, because I know it wasn't working too well before. Well, thank you so much, everybody, for joining us today for our CATHIP session on COPD. Lovely to have you, Dr. Kamara, so thank you so much again for being with us. So what's happening, and then for you to come back and join us again. Lovely session on headaches or migraines.
Sorry, Ruth, you're breaking up. Can you turn your camera off and let's see if that gets any better? Yeah.
Is that any better?
No, it's still breaking up, unfortunately.
Right. So fellow audience, next week we're going to be looking at headaches and migraines and what the differences are. But once again, as with all sessions, this will be focusing on prevention, long-term management, and then how you look after yourself in a practical way. Next slide, please. So on Tuesdays, as you all know, we do have a session focused on nutrition and physical activity. And coming Tuesday, we're looking at healthy lifestyles and, for healthy aging. Because whether we like it or not, we're all going to age at some point in time. Between 6 p.m. and 7:30, we shall be focused on that. Guest speaker is Alistair Kumi for next week. Next slide. And yes, we do have a family and advocacy support session. We have one coming up on the 14th of June, so please make a note and links will be shared in the chat. A couple of other services you could benefit from if you are bereaved. There's a peer support group, so drop us an email, health@CAHN.org.uk or help@CAHN.org.uk, and we shall share further information. And also just worth mentioning, because we have other partners that bring this program to you. Depending on where you live, our partners may have a range of services and activities as well. So if you're in London, Leeds, Birmingham, Sheffield, and you need any sort of practical support, then let us know. The next slide, please. Yes, this is about Green and Arts Wellbeing Service. It's sunny. I know there's football later on, but we encourage people to use green spaces and get out there, walk, do some arts as well. And all those things could help improve your mental well-being. Next slide, please. Yes, there's an ongoing survey. We want to understand the cost of living prices and how that is impacting on our community. So, there's lots of household support fund out there, but we know there are people in our community without recourse to public funds. Therefore, please complete the survey, give us your feedback, and let us know how you're coping during these times. So as many of you are aware, this year is the 75th anniversary of the arrival of, the Windrush generation to support the NHS and other sectors. So right across the country, there will be a range of events. 22nd of June is National Windrush Day, but in Greater Manchester, we have our event on the 24th of June at Alexandra Park. I believe our partners will have events in Leeds, Birmingham, London, Sheffield. So look out for that, and we'll be sharing a lot more information with yourselves. I think the Enfield Caribbean Association have 3 fantastic events upcoming. So hopefully next week we'll share more details with you. Also look in the chat box, a couple of other events coming up. So once again, massive thanks to all our partners. Rafa International Development Agency, based in Birmingham, but working across the country. And feel free to check them on their website, reach out to them. Croydon BME Forum, Enfield Caribbean Association, the Black Health Initiative, and then RCCG, Royal House in Sheffield. And once again, massive thanks, everyone. Next week, we're back here, same Zoom details. Spread the word, invite someone else. It's on headaches and migraines. And sometimes I know we prescribe things for ourselves, but prevention is key. Health is wealth. Enjoy the sunshine, but look after yourselves. If you need sun cream, then put some on. Over to the team.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.